Even in people with migraine, it's been shown that may be more sensitive to side effects than people without migraine. Patients that get put on these oral preventive therapies, in 6 months, for patients with chronic migraine, only 1 in 4 continue to take their treatment. At 1 year, it's close to 10%. So we know that people are going to stop taking treatment. So how do we optimize that? I think it's going to be having that conversation, that shared decision making. If you have a side effect, let us know, because we can either work around that side effect, we can reduce the side effect. There's strategies. It's not all or none. So these are treatments that are used for multiple conditions. So when you have a drug that can be used for multiple conditions, including migraine, you may imagine that it may be associated with some side effects. Some side effects that we'll talk about may even be wanted to treat certain, even other comorbid conditions. It's not always easy to understand why someone has had a particular side effect. I would say that if you've had a side effect to a particular drug and you use a similar drug within that class, there's certainly a significant chance that you may also have a side effect to that drug that's within that class. Now, there's different routes of administration of triptans. There are nasal sprays, there are injectables. So some of the side effects may not be fully related to what we call a class effect. It can be related to the route of administration. For example, if you give someone a sumatriptan injectable therapy, they can respond very quickly, but they can also have pretty significant side effects like palpitations, for example, which they may not see with a nasal spray. Or if there are other options available, for example, you had a very severe side effect to a triptan, well, maybe that might be an opportunity to go to another drug class like a gepant or something else.